Before we start today's episode, I would like to quickly read you our podcast disclaimer. The content in this podcast is for general reference and educational purposes only. It is not meant to be complete or exhaustive or to be applicable to any specific individual's medical condition. No information provided in this podcast constitutes medical advice and is not an attempt to practice medicine or to provide specific medical advice, diagnosis, or treatment. This podcast does not create a physician-patient relationship and is not a substitute for professional medical advice, diagnosis, or treatment. Please do not rely on this podcast for emergency medical treatment. Remember that everyone is different, so make sure you consult your own healthcare professional before seeking any new treatment and before you alter, suspend, or initiate a new change in your routine. Welcome to The Starting Gate. We're your hosts, Dr. Kitty Dotson
and Dr. Sarah Sheets,
two internal medicine doctors who spent years practicing traditional primary care. Over time, we realized something was missing from modern healthcare. A real understanding of how everyday lifestyle choices impact overall health.
We'll help you cut through the noise of the countless health influencers and their conflicting opinions, because no matter who you follow, the basics of lifestyle medicine are at the heart of it all.
Welcome back to The Starting Gate. We're your hosts, Dr. Kitty Dotson
and Dr. Sarah Sheets.
Well, we've had a different last 2 weeks, and hopefully you've been able to listen to our last two episodes where Sarah really shared a lot with us about what she learned about fire safety. And we are going to be shifting focus now back to some of our usual topics. And the next few weeks, we will be focusing on musculoskeletal issues.
We really want to talk about some specific joints, chronic pain, as well as some preventative measures. Again, talking about some of those lifestyle options that you have for treating some of these joint pains that many people experience in their lifetime. And we're really excited to have different perspectives. We have a lot of different specialists that will be on the show to be able to provide great education for our listeners. Today, we are really excited to talk about knee pain.
Yes, we are going to be focusing specifically on osteoarthritis of the knee, and we are super excited to have our guest today, orthopedic surgeon from Bluegrass Orthopedics, Dr. Kevin Denehy.
Thanks so much for having me. I'm excited to be here.
We're so glad you came. Can you tell us a little bit about yourself and how you got into your field?
So my specialty is in what's called adult reconstruction. So that is hip and knee replacement of adults that have osteoarthritis. So when people are debilitated by arthritis of their knee or their hip, and they've failed conservative measures, we can do surgeries such as hip or knee replacements to resurface their joints to give them mobility and function back. I did most of my training in the Northeast, in and around Philadelphia, and then came out to Louisville, Kentucky to do a year of fellowship. My wife, family, and I fell in love with Kentucky, and we stayed here. And so we've been here for about 8 or 9 years now, and my practice is mostly based on doing hip and knee replacements. I probably do somewhere between 700 and 800 hip and knee replacements a year.
We're glad to have you in Kentucky.
That's a lot of hip and knees.
It's plenty of business out there. We stay busy.
So to get us started, can you just give an explanation of what is arthritis of the knee?
Sure. So arthritis of the knee has to do with losing the cartilage cap that's on the end of the joint. So at each joint, at the knee, it's where your femur meets your tibia. There's a smooth cap of cartilage that you're born with. Over time, for various reasons, you can lose that cap of cartilage and the bone underneath becomes exposed. Cartilage is a really unique thing. It's one of the most frictionless substances that we know of. And so when they study it in engineering, they try to make different products that can slide and glide easier over each other. You could imagine like an ice cube on a marble tabletop. As it starts to melt, it could really easily slide across that table. They really haven't in all of science been able to design or come up with anything that's smoother than cartilage. The other unique thing about cartilage is it doesn't have nerve ending. When you have that smooth cap of cartilage on the end of your bone, your joint works great. It glides back and forth nice and easily, and it's not painful. For whatever reason, over time, if you lose that cap of cartilage, the bone underneath is much rougher. Imagine rubbing two pieces of sandpaper together. And the bone also contains nerve endings, so it becomes painful when you load it or those joints rubbing up against each other. And so patients can have symptoms related to that.
And what would make your cartilage wear away over time?
There's multiple things that can happen. Excessive loading of the joint can cause it, and that's usually related to obesity. So obesity is a known risk factor for osteoarthritis of the knee. So patients that are overweight, loading that joint more. There's biomechanical studies that say that you put about 5 to 6 times your body weight across your knee joint just with walking. So you can imagine even 10, 15 pounds in excess of ideal body weight could start to really overload that joint, put more stress across it, and cause that cartilage to wear out over time. The other thing is trauma. So if you have an injury to the knee, so say you're in your 20s and you're playing soccer and you tear your ACL, you never have it fixed, that knee becomes unstable, or you've damaged the meniscus, one of the other structures inside the knee, and that can change how the joint is loaded and create some accelerated wear of the knee and create that cartilage to wear out earlier. There's probably some genetic components to it too. I'm sure everybody has a friend or a family member that maybe has multiple people in that family that have had hip or knee replacements, or they've had a knee replacement on one side and their other knee's worn out too. So there's some genetic component to this stuff that we probably don't fully understand yet. It's probably multifactorial. So we haven't found this one specific gene that says you're going to get arthritis, but it could be a group of different genetic components that will over time lead to the joint wearing out faster. So whether that's the structure of how your cartilage was built or the strength of the bone underlying it, all of those things could be potential, but there's probably multiple genes that are coming together there to cause those. The other thing that can wear your genes out faster is your alignment, right? Everybody's probably seen patients that are a little bit bow-legged or a little bit knock-kneed. We call that varus or valgus alignment of the knee. If you drew a line from the center of your hip all the way down to the center of your ankle, if the knee is outside the middle of that line, you're going to load the knee differently, and that could create, again, increased stress across the cartilage, which will wear the knee out faster.
What about for people who are longtime athletes or runners? Are they causing injury over those years of impact?
It's a great question. And people have studied this pretty extensively. The benefit from keeping the weight down by being a runner is probably more protective than increasing activity would make you more likely to wear out your knee faster. So when they study it, they look at maybe a recreational runner, somebody that runs 5 or 10 Ks, stays active and stays fit. Doing that seems to be protective of needing a knee replacement. If you look at super elite marathoners that have run marathons their entire life, that maybe is a little bit at risk, but it's probably about the same risk as somebody that's obese. That sweet spot of staying active and staying fit without going to super extremes of cardiovascular fitness is probably the best thing for you.
So you mentioned staying fit, you mentioned keeping your weight down. Are there any other big things that would help someone prevent getting osteoarthritis?
One thing I would mention is that there's a couple other reasons that people would need hip or knee replacements that can sometimes be a lifestyle thing. There's a condition called avascular necrosis, and that happens when the blood supply to the joint, whether it's the hip or the knee or the shoulder, gets cut off. And there's some risk factors associated with that. Smoking's a big one. So I see it a lot in my smoking population where the nicotine's constricting your blood vessels, and over time, the blood supply to that bone that's underlying that cartilage can be cut off, and then the bone supporting that cartilage dies. And that can create these conditions where you're going to need joint replacements earlier in life. That's also associated with high-dose steroids. So I saw a lot of it in young patients during COVID where they got a bad COVID and they needed steroids to save their lives and keep their lungs functioning. But some of the consequences of that, their joints have started to collapse. And then the other one is excessive alcohol use. So in heavy alcohol users, sometimes you can see that avascular necrosis. I think most people's doctors have told them that very high dose steroids, smoking and drinking aren't great for you. And it's just the same is true at the joint level as well. One thing about exercise, and this is kind of switching gears back to your exercise question, is we've talked about cardiovascular fitness. And I think cardiovascular fitness is very important for your heart, your lungs. It can do really good things for you for keeping a healthy weight. But I do think that our joints need to be loaded with weight. And I think one of the things that sometimes my patient population, a lot of the patients I deal with are 60 plus, and their version of exercise is I'm going to go out on a half hour, 45-minute walk. And a body weight walk, while that can burn some calories for you and get you out of the house, get you moving, it doesn't necessarily load your joint in a manner that is going to build strength and stability of that joint. And so I'm a big proponent of using some weighted exercises in your life as well. And we're not talking Arnold Schwarzenegger weights where you're deadlifting thousands of pounds or anything like that, but just some low weighted exercises where your muscles are pulling against resistance. Even if you want to go out on a walk with a backpack with 10 pounds in it or something like that, just something to give your body a little extra push. Our bodies are meant to be pushed. And if you don't have a stressor that they're responding to, they tend to degrade over time. So one of the common things that I see is a postmenopausal woman, 65, 70, who hasn't really done a lot of weighted exercises recently. and they get this acute meniscus tear. And so the meniscus is a thing that's structurally on the inside of the knee. It helps support both the medial and lateral sides of the knee, and it's anchored down to the bone by a root. And if you don't stress your knee and put some weight across your knee and put some physical exercises, those anchors become weakened over time, and you can get what's called a meniscal root tear, where the whole root tears out. And so a meniscus tear is something that's very different in a 65, 70-year-old person versus somebody that's in their 20s. A 20-year-old soccer player that tears a meniscus, that's somebody that you can go in, stitch the meniscus back up. It can heal over time, and you can get back to a pretty normal, healthy knee life. When you tear the meniscus at an older age or the root tears out, there are times where it's unlikely going to heal, even if it gets put back together surgically perfectly, and it can lead to earlier onset arthritis. And I really think if patients were active, loading the joint against resistance, those types of fibers would become stronger and be less likely to tear over time.
Are there any specific exercises in thinking about resistance training in particular that are great for knee?
Yeah. Some of them include walking with weights. I think that's a very simple one, because when you're trying to do this, it's hard to give advice. There's people that have certain levels of exercise, and so you don't want to have somebody going in where they haven't exercised in a long time, and then you're starting them, loading them with complex plyometric exercises where they're jumping off boxes or things like that. Trying to ramp up to that and be safe with it. It's pretty simple for most people to go out on a walk, but just put a backpack on that's got a couple bottles of water in it. You don't need high-tech gear to do that, but you can go out on, and that's just going to increase the load that's going across. Trying to do hills with that, I think, is helpful instead of just walking on flat ground. There's a lot of times patients will say, I went to the gym. They sat on a treadmill and played on their phone for 30 minutes and walked at a 1 mile an hour pace. Part of that exercise is challenging yourself. And so if you're not really feeling some resistance or some work, your body's not going to respond to it in the way that you want it to.
I did recently buy a weighted vest
Did
when
you?
it went on sale on Amazon.
Nice.
And I really, when I have that on and I'm walking up a hill, that's like really when I feel
That's
like
great.
I can feel that challenge.
Yeah.
And
yeah.
a lot of times, if you do use a wearable, or so many people do, that shows their heart rate, you can see a difference just doing the same walk with weights on or not. And you're like, okay, I'm doing more work. I feel it.
Absolutely. Some other ones that I usually recommend to patients, because the safest exercises to start on, especially if you've got a gym membership, and most of the senior citizen centers have a small gym that you can have access to, or Planet Fitness is a very cheap option. It's not like you spend huge amounts of money. It's simple, but even the Nautilus machines that are there are very safe inline exercises that you're very unlikely to hurt yourself on. But they work most of the major body parts that you need to work to build some muscle and strength, leg extensions, leg curls, leg presses. You can do them on a machine. You want to make sure that you can do 15 to 20 reps before you're pretty fatigued. That's probably a good weight to start at. So start with a low weight and kind of push yourself up. And I think that's a very good place to start. If you master that and those are feeling pretty easy, trying to find some resources, either from a physical therapist or a trainer, somebody that can push you to do some harder exercises. There's a ton of stuff online. One of the things I recommend for patients is there's a YouTube and an Instagram thing called Knees Over Toes, where they have a lot of great bodyweight resistance exercises you can find pretty easily online. And again, it's all free resources that you don't have to spend any money for, but they go through some things that give you some pretty good exercises that help strengthen and stabilize the knees without putting a ton of stress across them.
Oh, that's great. We'll put a link to that in our show notes.
Now, for our listeners, some of them may not have arthritis. So how would you explain to someone who hasn't experienced it what it feels like so they know, oh, maybe I'm getting arthritis in my knee?
The most common symptoms that I hear from people are usually startup pain. So if you've been sitting in a car or in a chair for a long period of time, you imagine that two pieces of sandpaper that we talked about before, they're stuck together now. There's none of that normal fluid that's moving around in the knee joint in between them. They get up to start going and their knee aches and is really sore. Once they get moving for a couple minutes, they can start to get some relief from the pain and they can walk okay. And then they're good for a period of time, but if they walk for more than 15, 20 minutes, then it starts to get sore again. And that's likely the physiology going on there is that when they first got up, those two bones were really stuck together. Once some fluid got in there and got it moving, they felt like there was some more mobility in the joint, didn't feel as stiff or as painful. But then once they're loading that bone for a period of time without that cartilage cap, it starts to become painful again. A lot of times patients will wake up at night in soreness and pain. They roll over in bed and the inside part of their knees hurting, wakes them up at night. Those are usually the symptoms that are getting people into my office to say, hey, something's going wrong and I want to get it evaluated.
One that I always heard a lot and instantly was like, oh my gosh, do I have arthritis? Is a medical term we use is crepitus, but like that sound, the cracking sound. Is that concerning?
So can be a lot of different things that cause that noise in the knee. So crepitus or crunching or cracking, people call it Rice Krispies of their knee. It's not necessarily always severe end-stage arthritis where you're going to need a knee replacement. There's things called plicas, which are these connective tissues that go across the knee that sometimes can create a snapping or a popping in the knee. There's also just sometimes people, even an injury that you didn't realize you had, but can create some scar tissue in the knee. And you can just feel that scar tissue moving back and forth across the knee. It's not necessarily just because you have some cracking and popping in the knee that you have arthritis, but if that cracking and popping is painful and sore, it's more likely.
Now, when in the spectrum of osteoarthritis, should patients expect to see swelling start to occur?
Most of the time in the end-stage severe portions of arthritis, you start to see what we call joint effusions, where there's fluid that builds up inside the joint. And that's really a reaction to that cartilage loss. Our body's trying to create this cushion that was there with the cartilage and isn't there anymore. And that cushion is that fluid. So the inside of all of our joints have a lining called a synovium, and those cells in the synovium can make this fluid, and they make it in response to that inflammation and can create swelling in that knee joint or that knee effusion. That usually comes towards the end stage of the arthritis when there's really a significant cartilage loss. A lot of times they come into the office and that fluid filling their knee is one of the more painful things. Most of the nerve endings in the knee joint are actually located in the joint capsule. And so when you fill the knee with fluid from the response to the inflammation, that capsule becomes on stretch. And then it's really hard to bend the knee or straighten the knee all the way because that capsule is so on stretch, and that becomes very painful for them. They get a ton of symptomatic relief from draining that fluid. So we'll numb them up around their knee. We can put a needle inside their knee and a syringe and draw that fluid off, and that can give them a lot of symptomatic relief.
Does that usually have a lasting effect, or?
It does not, unfortunately. Yeah. So it's very likely that because we haven't fixed the underlying problem that's causing it. So that is very much a temporary measure, but it can be a very positive temporary measure. And temporary can be a lot of different things. Drawing that fluid off and putting an injection into that knee, that can give people 6, 9 months, year of relief at times, depending on how severe their disease is, and buy them some time. But it's very unlikely going to be anything that's curative, that's going to reverse the arthritis they have in their knee and turn back the clocks of time so that their 20-year-old knee's back in them. Yeah, that's just, unfortunately, we're not there in medicine yet.
Let's talk about some of the things that maybe can buy people time. What about if someone is overweight and they're having a lot of knee pain and arthritis? Would losing weight help at that point?
Yes. I think there's very good studies and evidence out there that if you have symptomatic osteoarthritis of your knee and you lose even 10 to 15 pounds, patients' scores in terms of what their knee function is and what their pain scores are significantly decreased. Weight loss is a great thing to help take some of the stress and pain associated with osteoarthritis across your knee out. And the other great thing about weight loss is, and I'm sure we'll get to this later, but when we talk about surgery and risks involved in surgery, if you do end up needing knee replacement down the road, is having your weight at a more ideal body weight very much improves your chances of having a positive outcome from your knee replacement and having an outcome without complications like infection and other things.
Something that we like to talk about a lot on the show is nutrition. Have you found any specific diets or adjustments in patients' diets that have helped them with the pain or inflammation that they have?
Yeah, it's one of the harder things to do when we talked about it. So you've got bad arthritis of your knee and it's hard for you to get out and exercise and move. So really the way to achieve the weight loss is by caloric restriction. It's the caloric expenditure of going out and exercising and going on a 10-mile run is probably not going to happen if you have severe end-stage arthritis. It's really got to be focused on nutrition. The research and the data on specific diets it's tough one to examine. I think nutrition and diets in general, when they're research and study, it's just a really hard thing to always judge compliance. I think that's probably a tough part of any nutritional study is what the compliance is, and people's food recall of what they ate and what they didn't eat can be pretty challenging to actually tease into. And the other thing I think that is if people really care about their health to a point where they're adopting different diets and adopting certain anti-inflammatory diets, those are probably patients that are on the spectrum of health, probably a little bit healthier. And so it's hard to always quantify how much of that is correlation versus causative of, hey, is this just a really healthy person that's focusing on having this Mediterranean or anti-inflammatory diet versus somebody that probably doesn't care as much about their diet or their other factors in their health, or they're really paying attention to it. So there hasn't been any great studies that have shown that if you eat this diet, you're going to have less arthritic joint pain.
Yeah, and it's no matter what the condition is, nutrition is always the hardest thing to study because so much of it is subjective in the studies because we don't hide them away somewhere and make sure we know exactly what they're eating for like months to years.
Yes.
We can't do that. So it has to do with recall.
It's hard to get people to sign up for that study,
Yeah,
right?
exactly.
The one thing I do find in my patient population is that, especially as people age, I think you can argue a lot about different types of diets, but one of the things I see very commonly is people that are protein deficient. I think it's a struggle that they're not getting a ton of protein into their diet. I think that sometimes goes back to building that muscle mass and creating a stable joint. And if you're not giving your body the building blocks to grow protein or to have protein to be able to grow muscle, it's going to be harder for you to create a more stable knee that isn't going to flare up on you. There's patients that come into my office that are very active, very fit, and obviously taking a lot of care to build muscle and strength around their knee and have high protein diets. And because of that, I think that they are able to tolerate a degree of arthritis that we see on X-ray much better than somebody who does the opposite, right? So they come in and you look at their X-ray and you're like, wow, how are you walking around on that? And they're like, I just ran 3 miles and it's sore at the end of the day, but it's not killing me. I'm okay with it. And if you look at that X-ray and you're like, I can't believe they're walking on, somebody comes in who doesn't have that same muscle strength and doesn't do the same exercise, their ability to tolerate a much lower level of arthritis on their X-ray is pretty striking.
Well, that's a really good point. Another reason to focus on strength and protein in your diet. We talk about that a lot on here.
What about some natural remedies like turmeric or glucose chondroitin supplements? Do you see those having a beneficial effect?
The turmeric one I do. I think I've got a fair amount of patients that come in and they want something anti-inflammatory. They want to stay away from using strong non-steroidal anti-inflammatories like being on Motrin or Aleve or naproxen, and they want to try that first. And they get pretty good symptomatic relief from it. And I think there's pretty good data out there. That's one that people have studied, and I think it's pretty significant that the turmeric can be helpful. The glucosamine chondroitin, not so much. The other one I would loop into that one is there's a lot of people that try to ingest collagen or other types of proteins. And the struggle there is that your body's going to ingest that, and then it's going to break it down to its basic amino acids. So protein's made up of a lot of amino acids. When it goes into your stomach, breaks that down, those amino acids are absorbed into your system. And then when your body decides it needs to build new protein or build new cartilage or those types of things, those building blocks are there for them to build from. But just because you ingest the protein or glucosamine orally, it doesn't mean that it's going to magically end up at your knee and fill that cartilage gap that's missing. That's a huge step to take, right? I don't think that the pathway for that working makes a ton of sense to me. And if you look at large data, when they've studied this, it really doesn't seem to be much better than placebo. But I put these things into some categories where I don't think it's harmful, right? So I do have some patients that will come in to see me and they take it and I ask them how it helps them. And they say, I think it helps me a ton. And I feel much better when I take it than when I don't take it. And I don't think it's harming you. So if you take it and it's helpful for you and you can afford it and it's not super expensive, I don't think it's going to hurt you in any way. But I just don't think there's a very rational kind of pathway where, in my mind, it's going to get there and decrease the arthritis that you have in your knee. I think most of the large data studies on it haven't shown it to be that much better than placebo.
Well, another thing that's a hot topic right now is cold treatments of all sorts. So when we talk about we can go from the very basic, just using ice, all the way up to doing a cold plunge. What can someone expect with arthritis to get as a result from that?
They can get some short-term relief of inflammation. It's very well studied that if ice or use some cryotherapy on your knee after you've done something where it's inflamed, it can give you symptomatic relief for that kind of short period of time that you've got the ice on. But I don't think that there's very good data out there suggesting that if you cold plunge 3 times a week for 30 minutes, you're going to decrease your risk of having arthritis of your knee. There's people that think it helps them recover from a muscle standpoint faster after a big workout. And again, I still think that data is a little bit mixed, and I don't think there's really clear pathways, again, that it creates a huge difference. One of the things you run into with those types of studies is that the protocols are all over the place. And so when you
sometimes done with athletes, sometimes not, and then like it's all it hasn't been the best.
So it's hard to tease out, and do we go in for 5 minutes or 30 minutes or an hour? And everybody thinks that they've got it dialed in of this is the magic sauce to make it work. But I think when you really do it compared to placebo stuff, there hasn't, at least for arthritis of the knee, I think some of the muscle recovery stuff and high-end athletes may be a little bit different. But for arthritis of the knee, there's not a huge difference.
So really thinking it more of, I'm having significant pain, I'm going to use ice as a way to treat it.
Exactly.
Okay.
I think that'll give you some short-term relief of, I did something where I was really active on my knee and it swelled up and it's sore on me. I'm going to try this before I go in to see the doc to see if it helps me get it through that acute inflammation of 2 to 3 days versus, hey, I'm doing this daily as a remedy for long-term treatment of arthritis. The other thing that's out there that people might read about or hear about is cryotherapy, a thing called iovera is a product name, but it's a nerve ablation type procedure that sometimes people use as a non-operative treatment of arthritis. And the idea behind that is that you find the small superficial nerves, they're called the genicular nerves around the knee, that supply sensation around the knee. And usually an anesthesiologist or a CRNA that's trained to do it can use ultrasound and find these very small superficial nerves. And they can do either a freezing or a burning of those nerves that can give some, again, usually temporary relief of pain around the knee. It tends not to be permanent. The nerves will come back over time, but can give some temporary relief for knee pain. And so that's another thing that's in that cryotherapy. If you Google that, you might find, again, it's not a long-term solution. You're not fixing any of the underlying causes of the pain in the knee, but it's something that people have used to try to treat some of the nerve pain around the knee.
And on the flip side, is there any evidence behind using heat to help with anything?
Again, it's one of those, it can symptomatically make you feel better for a short period of time, can help with some blood flow to the area if the knee is feeling stiff and things like that. But again, long-term, is it going to change any of the real downstream outcomes of where you're going to end up with knee arthritis? Probably not. When we were talking about the turmerics and glucosamine chondroitins, the other thing that a lot of times that we'll try with patients is just oral anti-inflammatories. And I think that those can be really helpful. And if they're taken at the doses that are prescribed and your primary care doc's checking your kidney function, they're very safe medications to take. I think there's a lot of times patients have this hesitancy of, oh, I was told that that's going to give me kidney failure and I can't be on those forever. I have patients that take a low-dose anti-inflammatory every day, and it really helps them with their knee pain, and they're able to avoid surgery for long periods of time because of the anti-inflammatory. I think a lot of times using the selective COX-2 inhibitors, so the COX enzymes are some of the inflammatory enzymes in the body, and most of the over-the-counter anti-inflammatories, things you think about like Motrin or Aleve, are very non-selective COX inhibitors that kind of inhibit all the COX enzymes. Things like meloxicam and Celebrex are more prescription strength ones that specifically inhibit a COX-2 enzymes. It's probably a little bit more specific for knee and hip osteoarthritis, so it works a little bit better, a little bit stronger, and they can be very helpful. The one thing I do tell patients is that opiates are not a great treatment for knee arthritis. It's a chronic condition, and trying to use opiates to treat a chronic condition is not a great pathway. That's something that could lead to addiction and things like that. So a lot of times patients will come in and they'll be asking, Doc, can I just get some oxycodone or tramadol or something like that for treatment? I'm hesitant to do those types of things because starting somebody on an opiate for a chronic condition is somewhat of a dangerous thing to do because you're not really fixing the underlying problem. There's a chance you could lead somebody down the pathway to addiction. And I think if you're acute postoperative surgically, they need them for periods of time, but not something that anybody, I think, would routinely start somebody on for a chronic condition like that.
And before you leave those anti-inflammatories, do you see much benefit from people that use Voltaren gel, like a topical NSAID?
Yes, absolutely. Especially if they've got specific areas in the knee, whether it's medial or lateral, where they're having pain. A lot of patients are able to tolerate that better, especially if they've got a little bit more questionable kidney function. And their primary care doc said, I think the topical one's not going to have as much systemic effect on you, and you can kind of use it locally. Definitely get some patients that get benefit from that. I think there's pretty good studies that it's better than a placebo of just rubbing a cream on your leg, that it does improve patient symptoms for sure.
Let's just talk about this progression. Maybe someone has been on an anti-inflammatory for a while and they come in and they're like, it's not doing anymore. Is that when you're moving towards an injection?
Yes. And the only other thing I would offer them before the injection, because sometimes patients are like, I don't want to have a needle in my knee. I'm terrified of needles, and they want to do everything they can before needles, is sometimes bracing can be helpful for patients. There are these what we call offloader braces, where you imagine we talked about those knees that aren't aligned from their hip down to their ankle. So say you have a pretty good bow to your leg, and that's the more common one where the legs are bowed out versus being knock-kneed. So we call that varus alignment. So if you have a varus aligned knee, that you can put a brace on where it puts some pressure above and below the knee on the inside and pressure at the knee on the outside, and almost pushes that outside of the knee in to help straighten the alignment and offload that inside part of the knee where the majority of the arthritis is. And that can be somewhat successful for patients. The problem is compliance. I think that's, again, you're wearing a brace for a week or two while you're recovering from an injury. This is going to be like a chronic thing that you're living with arthritis to your knee. And every time you go golfing or go hiking, you're going to have to put this brace on to be comfortable. But for some patients, it doesn't bother them that much and they're able to live with it. But most patients try it. And by the time like spring and summer hits and they're sweating in their brace and don't want to put it on, they're like, I want to find something else. So that one is out there, and it's one of the things that people do talk about. Once those have failed, then the next thing we talk about are injections.
What about just like a compression pull-on sleeve for the knee? Is that helpful for anything?
And I think it can maybe help a little bit with some soft tissue swelling. So if you have some swelling about the knee, those compression sleeves can be helpful. You see the advertisements on TVs for like copper fit,
Yes.
That this copper is going to create this extra blood flow. That's it. I don't think that there's really good data there that shows that there's a difference between having a compression sleeve that has copper in it versus one that doesn't. But again, placebo benefits are real. And so if the copper one helps somebody more than the other one, I don't think it's harming them. So again, it's that category of no harm. But if it does help you, we're not going to say you can't do it. But when they study it and look at that compared to an offloader brace, a brace that puts pressure on the knee that help with the alignment, the offloader braces do much better than just a compression sleeve.
All right. So injections. If we're here and someone's coming to see you in the office, there are lots of types of injections. So where do you start? And what does someone typically receive? And then if that doesn't work, are there other options? Because this gets really muddy.
It
I feel
does.
like.
There's a lot of questions around this in the office when patients come in. Yeah. And I think a lot of the reason there's a lot of questions is it's one of those things in medicine where it's advertised a lot on television. And so if you see a lot of advertisements for something on television or on social media, sometimes the people that are advertising for them don't always give you all the real information and maybe overstate what things are going to do. For financial benefits, they can create some confusion. So one of the more basic injections that people hear about is a steroid injection or cortisone injection. And that is taking that anti-inflammatory pill that we would give you and taking that anti-inflammatory and putting it directly in the knee. So it's a steroid, usually cortisone or dexamethasone, that is injected into the knee. We can do it in the office. It's not an invasive procedure. I tell most patients it's really like getting a flu shot. It's not incredibly painful, and it can provide very symptomatic relief. Those injections are usually covered by almost all insurances, so there's no prior authorization to go through. There's no specialty pharmacy that you have to go through to acquire the medicine. You can come in, see me the day you're in the office. We talk about all your arthritis. We talk about everything that we've talked about so far. And you say, my primary's already put me on Celebrex and I've tried a brace and it didn't really help me, but I want to do an injection before surgery to see if it helps me. And we can do an injection in the office that day. You can walk out and you can get back to your normal activities. We don't restrict you at all. And it can be very beneficial for patients. And
how many days would it take before the patient notices a difference?
so we usually put in the injection a long-acting numbing medication. Bupivacaine is usually the one we use, which is similar to a Novocaine that you get at the dentist. So honestly, by the time they leave the office and get to their car, they're usually feeling that numbing medication's kicked in. Now, that only lasts for an hour or two and then starts to wear off. The steroid can take 24 hours or so to kick in.
And how long do they usually work?
That's a magic question, right? And that's different for everybody. And probably likely has to do with the severity of arthritis in their knee. So if you're looking at an x-ray and somebody has got 9 out of 10 or 10 out of 10 severity of arthritis on their x-ray, you're less likely that those injection is going to help them for a year or make them feel better. Now, if somebody has very mild arthritis in their knee and just did something acutely flared up and we put a steroid injection in there, those can be successful and work for a year or so. And so I've got a lot of patients that come in every 6 months, 9 months, a year, and just get an injection. It makes them feel better for that long period of time. And they're doing everything they want to do in life, and we can avoid surgery.
Is 6 months the closest you would give
3 months. 3 months
Okay.
for 3 months for a steroid. So you can get a steroid injection every 3 months, and that's shown to be very safe. One of those fallacies that are out there is that patients will ask is, can I get too many steroid injections? So if I got more than 10 steroid injections in my life, is it going my knee's going to fall off, or right? And that's very unlikely true. They did some studies where they looked at like rabbit models, and they were injecting very high dose of steroids and to see if there was any acceleration of cartilage damage or wear with the steroid injection. And there really wasn't. They found the preservative in one of the numbing medications might have been a little toxic to cartilage at a very high level, higher than what we'd be giving it. So it's very safe to get a steroid injection every 3 months. And it's very unlikely going to increase or accelerate your arthritis in your knee. There is a chance that over time your arthritis accelerates and the injections stop working as well, but it's very unlikely the steroid would cause an acceleration in your cartilage wear.
So someone could keep getting steroid injections as long as they were working?
Exactly.
Okay.
As long as they're beneficial for you, we keep doing them. And then the other type of injection that's out there, and this one's all over TV, so people see this a lot, of what we call gel injections or rooster comb injections, and those are a substance that's called hyaluronic acid.
Can you give some of the names that people might be seeing?
So there's like Gel 1 or Zelgens, there's Orthovisc, Monovisc, there's a whole bunch of different ones out there. And the other confusing part is, and somebody's friend might have had them where they had like a series of 4 or 5, where each week they came in for an injection, and then there's ones where you just get a one-time injection. So there's a bunch of different companies that make them. There's a bunch of different ways to administer them. And so that creates this kind of extra layer of confusion of what's the best. So just to cycle back to the way that they work, it's this very thick gel-like substance, and that at a molecular level creates what we call an osmotic gradient, where something's very thick and pushes fluid back into another area. And so the idea is that you put this thick gel into the knee, and that any cartilage that you have left in the knee will become rehydrated. So it pushes any fluid that you have into your knee back into the cartilage, helps rehydrate the cartilage that you have. Again, much more successful in patients that have not as severe arthritis because you have more cartilage left to rehydrate, but can be very beneficial, and is probably more beneficial than placebo in very controlled studies. The way that it's administered can be variable. What we talked about, whether it's 4 injections, 1 every week for 4 weeks, or a single injection all at one time. And the way that came about was how these companies got their FDA clearance. When the medicines first came out, they weren't sure if people would have reactions to them, so they wanted to give them lower doses spread out. And so they got their FDA clearance for, hey, every 4 weeks you're going to come in and get a small dose of the injection, and then they didn't really see any reactions. So the next company that came out with one was, well, let's try it every 3, and then let's try just one big injection. And you laugh, and it's funny, but that's the history of how they became this way. And so what they found over time is that 1 injection works just as well as 4 injections spread out. And it's just much logistically easier for a patient to come in once than one time for every week for 4 weeks. And the other thing, the companies will all tell you that, hey, 1 injection's better than the other. And that's really not true. When they study and look at it, it's pretty equivalent across the board of what types of improvement patients get. And so the way logistically it works in the office now, though, is that most of them require a prior authorization and approval through insurance companies to get them. And they're pretty expensive out of pocket. So usually you have to come in, see the doc and say, hey, we want to try this gel injection. So I'll usually start somebody out with the steroid because I can do that in the office the day of and doesn't require anything extra. If it helps them, we keep going with the steroid injection. If it doesn't help them, then we have another option of trying a gel injection. And we just have to do some work on the office end to get that stuff approved for the patients.
So there's no advantage of trying to alternate between the two since they have different mechanisms, or is that a strategy that people use?
Absolutely. And the other thing, and then this has to do with insurance approval things, is that the insurance companies won't authorize them but every 6 months. So if you can have a gel injection, but it maybe doesn't last you the full 6 months, what you can do is say after 3 or 4 months, come in and get a steroid injection. And that steroid injection can hold you over until the gel injection is approved for the next 6 months. So a lot of times we'll have to do that.
Does the gel, by rehydrating the cartilage, does that slow cartilage breakdown over time at all?
Probably not. There's not a lot of good evidence that there's a decrease in the rate that somebody progresses to needing knee replacement surgery, whether they've been on gel injections or steroid injections. And then the other injections out there that people talk a lot about are PRP and stem cells. So PRP is called platelet-rich plasma. You imagine you draw it off peripheral blood like you were doing a blood test on somebody out of their arm. And in the office, you can take that blood and put it in a centrifuge and spin down the blood. And so the red blood cells that are in your blood are the heaviest, so they'll fall to the bottom. And then what's left at the top is this we call plasma, and it's got a lot of proteins in it that are normally floating around in your blood. And some of those proteins have an anti-inflammatory effect. So they'll take that top part of the blood that they've taken the red blood cells out of and then inject it into a joint that has arthritis. The evidence behind that being beneficial to people is positive, right? So whether you got a steroid injection, a gel injection, or a platelet-rich plasma or PRP injection, when they study those three against each other, they all work well and decrease inflammation of the knee and improve patients' pain scores and functional scores and do that better than a placebo injection would do. But no one of them works better than the other. So they're all pretty similar in terms of how much they help people, and there's not a huge difference that PRP is drastically better than a steroid injection. I think anecdotally, patients in practice, that some people respond better to a gel injection than a steroid injection, and some people, the gel injections don't help them at all, and a steroid injection works great for them. There's definitely individual variability, but when you study thousands of patients and compare it to placebo, they all do a little bit better than placebo, but not one of them's drastically better than the other one.
Does insurance cover PRP?
It does not. So that's an out-of-pocket cost, and depending on where you have it done, I think probably you can find some places that you can do it for $300 or $400. Some places charge thousands, and they'll tell you that they've got a different PRP mix, but it's really just they're just trying to profit off of it. So it's probably about $300 to $400 out of pocket cash price that you'd have to pay for that. And again, I don't think it's something that's harmful to you. I think it's probably something that will improve your symptoms a bit because there are some anti-inflammatory effects of the PRP. But I think there's a lot of, again, because it's something that patients have to pay cash for, there's a lot of advertisements out there on it. And people will try to sell you that this is going to take this biology that came out of your blood, it's going to go into your knee, it's going to regrow cartilage, fix meniscus tears, repair all this damage that's done over years. And that's really just untrue. So it has some anti-inflammatory effects, but I don't think it's ever going to reverse the damage that you have in your knee. But unfortunately, a lot of times it's marketed that way. And even the gel injections, and you look at some of the TV advertisements for that, and the gel injections are, hey, the doc told me I needed a knee replacement, but I went to this center and they put a gel injection in me, and now I don't need a knee replacement. I think there's a little bit of exaggeration when you come to the marketing aspect of those things that a lot of patients see that ends up we're answering those questions in the office of is this going to help you?
So really it's just knowing, hey, I'm having these injections to manage my symptoms. I'm not curing my arthritis.
Exactly, yes.
Okay,
And
on all of these.
And I think the biggest one is the one we haven't talked about, stem cells. That's the one that's a Wild West, where patients are getting charged $10,000, $15,000, $20,000 I've seen. In this one, with the stem cell, what they do is they draw blood, instead of out of a vein in your arm, they draw it out of your pelvis. So they'll drill into the pelvis and draw blood out of the pelvis. And that blood is the blood cells that form kind of the different cells in our body. They have the potential to grow into all the cells in our body. And then they take that blood and they inject it into the knee joint. And again, I think it does actually have some anti-inflammatory effects. I think it's just like the PRP, where there are some proteins that are floating around in there that are somewhat anti-inflammatory and can make patients symptomatically better for a short period of time. But the idea that you're going to take this cell that can grow into anything, extract it from the pelvis, and then put it into a knee joint, and it's magically going to find the right signaling pathways to regrow cartilage just in the spots of the knee where your cartilage is missing, is pretty far-fetched. And the evidence behind it's just not true. So there's a lot of people that have taken a lot of time to try to prove that the stem cells, because they're, again, profitable, are drastically beneficial. But it's really just not there.
Really just trying to make this as simple as possible, too, for people to understand. When you have arthritis, you really can't reverse it. You can do different things to manage your symptoms from it. Even things like losing weight or maybe building more muscle around the knee might help prevent the symptoms from being as bad, but you can't reverse the damage that is done.
Correct. I think that's a great way to simplify it. And all the things we're doing are just managing symptoms. So whether that's pills that you're taking, gels that you're putting on there, braces that you're wearing, injections that you're putting into the knee, all just trying to do symptom management until you end up needing surgery.
And that takes us to our next question. So when do you actually say, hey, it's time to have a knee replacement?
It's a great question. And a lot of times patients come in and say, doc, should I get a knee replacement? And my mantra to patients is that I can never be the one to tell you need a knee replacement. I can look at an x-ray and say, on this x-ray, you've lost all the cartilage in your knee, and right now the bone is touching the bone. And I think knee replacement surgery would probably be beneficial for you and could make you symptomatically better, but your symptoms have to be there. And so I think that's the biggest thing. So when a patient comes in to see me, one of the first things I do is I ask them to tell me what's going on with their knee and what things in their life are they able to do and not able to do based on how their knee feels. And I think those are usually the drivers of getting people to say, yes, I want to have a knee replacement. If their knee's hurting them so bad, they can't go to their grandkids' football game because they can't walk up the bleacher stairs because their knee's in so much pain. That's a quality of life thing that patients want to be able to go see their grandkids play football or play soccer or whatever. They want to go out on a walk with their spouse at night to keep that cardiovascular fitness and things up. They go out and they're out for 10 minutes and their knee's throbbing them and they can't sleep that night because they're hurting so bad. So I usually try to really tease out what kind of quality of life things are affecting the patient. And so when it's creating this issue where you're not doing the things in life that you want to do, that's when I really think it's time to fix it. Because again, you can have these patients that have x-rays that look terrible and they are able to really function and do well. And then you get some x-rays that are like, oh, yeah, it's pretty worn out. They can't function. And it really has to do with what the patients are feeling and how they're able to manage their symptoms in their life.
I know one thing with my patients, when we would have these discussions, they were concerned about, I want to wait until a certain age because I'm afraid I will outlive the length of my knee replacement. So what is that strategy? How long do they last? Is that something that's a reasonable thing to think about?
Absolutely. And so a lot of what I do is I take care of a lot of revision knee work or in revision hip work as well, where somebody's had a hip or knee replacement and it's either worn out over time or something's gone wrong with it. It needs to get redone. And so I take care of a lot of those patients. It's probably about 20% of what I do is the redo ones. And so very aware of that being a risk, but I think you have to balance that quality of life. I've replaced knees of patients in their 30s and hips of, I think my youngest is 18, where they had some developmental issues. We had to do a hip replacement at 18. We definitely get patients in their early 30s where they had an ACL injury as a kid that got neglected and now their knee is completely unstable and worn out. They can't go on a walk with their kid or they can't play soccer with them in the backyard or do the things that they want to do, and their quality of life is really bad and they can't exercise or stay fit. And then you have that discussion with them. You say, hey, even though you're very young, the disease in your knee is very severe and you're balancing a quality of life versus a potential risk that later in life this might need to get redone. And that's a frank, honest conversation with them. I don't think that there's a magic age that you have to wait to. And I think in the past, people have been told that you have to wait till you're 65 or you have to get over this certain number and then it's okay. And I really think if somebody's suffering and hurting and their quality of life is terrible, making them get to an arbitrary age probably doesn't make a lot of sense to me. But then we have the conversation about how long do they last? And it's a tough question to answer. And the reason is because the data and the literature that we have on how long knee replacement lasts is based on the knee replacements we put in 25 years ago. It's true because to really study it well is you have to have it in somebody for a certain amount of time and see all right, so the ones we put in 25 years ago, how many of them are still here today working well and functioning? And the answer to that question is if you had a knee replacement 20 to 25 years ago, the survivorship is probably between 80 to 85%, depending on which study you read. Those are the ranges. But there's a couple of things that our technology's gotten a lot better. So we use a lot of different technology. You think about how you made a phone call 25 years ago versus how we make one today. Things have changed. And the same thing has changed in the manufacturing process of the implant. And especially the plastic parts, they've gotten a lot more sophisticated of how they make the plastic parts that go in between the femur and the tibia. And so that has really solved a lot of the issues of those things wearing out earlier and creating inflammation in the knee. And the other thing is 25 years ago, we probably cared less about the patient as a host and deciding when's the right time to do a knee replacement on somebody and optimizing a patient before surgery. So 25 years ago, nobody would check to see if you were a diabetic. And if you were a diabetic, what your A1C was. Probably didn't really care if you were a smoker. They would just say, oh, your knee's worn out, we're going to do knee replacement on you. And if you have that patient where their knee replacement fails, whether it's because of infection or it didn't heal to the bone, or the wound came open, that counts as a failure of this implant didn't survive. So those numbers probably inflate the risk of having to have it redone. So I think with all that being said, and it's a long-winded answer, but what I tell patients is that if you have a knee replacement and you get through your first year without complications, and we put in good overall alignment and with the quality parts that we're putting in today, I think there's a good chance they last you 30 years.
Oh, that's good.
Yeah, that's great. That's great. So you mentioned diabetes and that kind of thing. What things might a patient have to optimize before they could get a knee?
The three big ones that we talk about for most patients are diabetic control. So we'll start with that one. You brought it up. So we want their A1C less than 7. And every once in a while, we'll go between 7 and 7.5 if somebody's really elderly and they're really struggling to bring their A1C down below that, and their blood sugar is dropping too low, and that can be at risk. And sometimes in the elderly patients, it's harder to bring them down. But ideally, we want it below 7. There's another marker for diabetes that we test called fructosamine. That's more of an acute one, and that's been shown in our literature to be a little bit more sensitive than just the A1C. It just measures it for a couple of weeks instead of a couple of months of what people's blood sugars are. And we really like that number below 293. It's an odd number, but that's where the statistic bore out. So those are big ones. Smoking, we really want people not smoking and off of nicotine products in general. A lot of times patients will smoke, but I vape, and they're still getting nicotine into their system, which is going to inhibit their wound healing. And then outside of nicotine use and diabetes, the other one we look at is obesity. And ideally we want our BMIs below 40. Our 40 to 45 is a bit of a gray zone, where if you don't have other risk factors, if you're otherwise pretty healthy and young, a lot of times that's one where we'll talk to the patients and counsel them, hey, can we lose a little bit of weight here? Or are you really stuck? Do you have such severe disease that you're wheelchair bound, and trying to ask you to lose weight is probably not going to be that likely. That's a bit of a gray zone. I think over 45, most of us that are fellowship trained hip and knee replacement docs have kind of said that's where the risk factor really jumps pretty high. Once you get over 45 on a BMI, it's about 5 to 6 times higher risk of infection. But the opposite's true. So if you have a BMI below 20, sometimes you're nutritionally depleted and your risk can go up as well. That kind of sweet spot is there. We do check some nutrition labs as well to make sure. We talked about protein intake as a big one before. So before everybody's surgery, they get labs like called albumin and pre-albumin and transferrin to make sure kind of nutritional labs are optimized beforehand. So there's a lot of work that we put in on the front side of surgery to make sure patients are as optimized as possible so that they can have the best outcome.
And I know a question that I got a lot was, why are we so worried about an infection? Can't I just take an antibiotic?
Yeah, it would make my life a lot easier.
Would it?
Yeah, it would. Yeah, and because I deal with a lot of infections that end up showing up. And if you're one of the people that are fellowship trained where this is all you do is hip and knee replacement, you end up taking care of people that don't take care of infections as very much, but like they still do hip and knee replacement. So you end up managing those patients. And it is a huge complication to have happen, right? So if you get an infection in a knee replacement, unfortunately, once you have a foreign body and with metal and plastic inside you, if you get a bacteria that lands on a skin cell, that skin cell is going to die. It's going to turn over. Your body will engulf it, and it can get rid of it. If bacteria land on a knee replacement, unfortunately, the bacteria will bind on there, and they don't let go. And it's not going to be turned over. That thing's permanently in you. And so the bacteria multiply, and they almost form like a force field around the rest of the body getting into the knee to be able to fight it. Most of our joints don't have a lot of blood supply in them. They're pretty avascular. That's why cartilage doesn't have a real blood supply to it. The knee joint itself is kind of walled off from the rest of the body, which is a perfect place for that bacteria to grow and grow. So if you get an infection and a knee replacement, usually what has to happen is that the entire knee replacement has to come out. And we do a big cleanup of the knee, but we got to take the knee replacement that was well fixed to your bone out, which can create some damage. And then we have to put in what's called a temporary antibiotic spacer that stays in for about 2 to 3 months while your body clears the infection and you're on IV antibiotics for that whole time. And then after we're confident that you cleared the infection, you go back for a third surgery to put another permanent knee replacement in. That's probably never going to be as good as the first one that we put in because you've got all this extra bone loss and damage to ligaments and tendons around the knee. And then once you've had an infection in the knee once, you're at much higher risk for having recurrent infections in the knee. And so it can be a pretty big catastrophe and a huge issue in people's lives to go through. I think anybody that does a lot of hip and knee replacements, we're pretty retentive and just like sticklers for sterility and cleanliness and trying to optimize as much as we can because infection is such a bad complication to have afterwards.
And I think that's important because I think some people, when they hear, oh, I'm at risk of infection, they're just thinking of a wound infection, something very superficial. But these are a much bigger deal. So that's why optimizing these specific things are so important prior to a surgery.
One of the things I tell people, because again, I take care of a lot of patients that end up infected, is that the mortality rate, so the death rate of somebody that gets diagnosed with a hip or knee replacement infection is 25% at 5 years. So if you get diagnosed with an infection in your hip or your knee replacement, you have a 1 in 4 chance of dying in 5 years. Yeah, it's pretty sobering, right? Yeah. So it really is. And to be fair, a lot of those are like sick people at their end of their life that get infected for other reasons, but it's a major hit to your system. It's multiple more surgeries, and they tend to be sicker patients that get them. So that's why we try to optimize as much as we can beforehand.
Some other things that people ask about is they're nervous about getting one of these surgeries and they're concerned about even going under for anesthesia. So does everyone have general anesthesia for a knee replacement now?
That's a great question. No, almost all of our anesthesia is done under spinal anesthetic. And we talked about the young patients that need hip or knee replacements and doing it early in life where you worry about that wearing out over time and needing to have it redone. But a lot of times it's more elderly patients that the one I see a lot is that you had a married couple where one of the spouses was sick and they put off having the replacement for a long period of time because they were being a caregiver. And so they've pushed it out 5, 6, 7 years from when they probably needed it because they were doing caregiving role. And then somebody passes away and they're finally able to get it done. But now they're almost a decade later into their life and they're very much concerned about, hey, if I undergo general anesthesia, is that going to give me this dementia? Am I going to be confused and really worried about the side effects of undergoing a general anesthetic? So for probably 95 to 98% of patients, we're able to do the surgery under spinal anesthetic, where the anesthesiologist gives you some numbing medication that just numbs you up from the belly button down. You can be awake the entire time you're having the operation. They usually make you sleepy. So the patients are like, I want to be awake. I don't want to hear what's going on. But they do make you sleepy. They usually, the other thing that we found, this is a little interesting, is they put big noise canceling headphones on you. When you listen to your favorite music, there's some evidence that can actually decrease the stress response in your body if you're listening to music that you enjoy. So it's crazy, but patients take fewer narcotics after surgery if they listen to music that they like during surgery.
Wow, I love
really
that.
Does decrease the stress response. But the other thing that's great about the spinal, there's a lot of good things about it. So not only does it decrease any cognitive issues after surgery of having to have all the drugs that put you all the way to sleep and a tube down your throat breathing for you, but it blocks all of the nerve fibers that would fire an inflammatory response in response to the surgery, the trauma that we're doing when we're doing the operation. So it blocks those ahead of time. So pain scores are less after surgery if you have it with a spinal. Infection rates less. And that's probably due to bleeding risk goes down. So when you have a spinal anesthetic, it keeps your blood pressure artificially lower. And so there's less bleeding, and that is probably the correlative to a lower infection rate. And then other things like urinary retention, GI upset, nausea and vomiting, all those things are less under spinal. So what I usually tell patients is if you can study like a postoperative outcome after a knee replacement, almost every single one of them is better if we do it under spinal in general.
And if you do it under spinal, does that make it more likely that you can do your surgery as an outpatient?
Yes. So I think the things like urinary retention and postoperative nausea and vomiting are less under a spinal. Sometimes you have to hang out a little bit longer. They've gotten really good at doing the spinals and putting just the right dose of medication in. And they've played around with different types of spinal medications that are more reliable in how long they act. Because if you put a spinal in and then it lasts for 4 hours, then it can be like kind of harder for you to get up and go and be safe to go home. But over the last 5 to 10 years, they've really found the best mixture of this combination of this dose of medication reliably gives you about 1.5 hours to 2 hours of spinal so that you can get through your surgery, but it wears off. Some of the other ones, they would last for 1.5 hours, but on other people, they would last for 4 hours. And so you had to find that sweet spot. But anesthesiologists have that pretty dialed in now. It does make it a little easier for you to go home. And that's one of the other things with joint replacements now is I think 15, 20 years ago, patients would think about having a hip or knee replacement and they would stay in the hospital for 5 or 6 nights and be on IV pain medication and then go to rehab for a month afterwards. And that's really not the case now. We've gotten so much better at lowering blood loss, lowering pain scores with things like spinals or blocks and preemptive medications that probably 70% of my total joint replacements that I do are done as an outpatient at a freestanding surgical center where patients go home the same day. They never have to be in a hospital. It's much more convenient for patients to come in. They don't have to park in a big parking garage or anything like that. They can pull up, have their surgery, easy in and out for families. And the other thing is the hospitals are full of sick people. And so if we can keep these healthy people that aren't sick, they're just going to be a little bit sore from surgery away from the sick people at the hospital that have infections and have other things, that's probably better overall too.
And then for these people that are getting to go home without complications, what is the typical recovery time?
So recovery from knee replacement, it comes in stages. And anybody that's had a knee replacement will probably tell you that it can be pretty rough in the first couple of weeks. So there's definitely some pain control and it's going to be sore. This isn't a cakewalk. A lot of times patients think, oh, My neighbor said he was walking day 2 without a cane and was golfing at day 5 and doing backflips. And I think there's some revisionist history that goes in there. But I think the biggest key is patients being prepared for it and making sure that they have some home support. So you're going to go home same day of surgery. You want to make sure somebody's around the house to help you keep an eye on you after the anesthesia that you have. But then planning on taking those first 2 weeks and just really not doing much at all. You want to keep the leg elevated. You want to keep ice on it, help keep your swelling down. You can get up for 5-10 minutes at a time, but for most of the day, you're just resting at the house with the leg elevated. Usually now we have a therapist that'll come out to the house to work with you in those first 2 weeks. Again, we're trying to limit how much you do and how active you are. So if the therapist can come to you for the first 2 weeks, that's probably better. And then after 2 weeks, we'll usually get you into some outpatient physical therapy where they've got more machines and equipment at the gym to help get you stronger. And people tend to do PT for about 2 months after surgery just to finish off getting the knee strong. Most people use a walker for a week or two, a cane for a week or two. I'll usually see people back in the office around 2 weeks. Most of them are just using a cane outside the house for balance. Patients that work desk jobs are usually back between 6 and 8 weeks of getting back to a desk job. And then more heavy-duty labor jobs is more like 8 to 10 weeks of getting back, where you got to be on your feet all day, carrying, pushing, pulling things. That's a little bit longer recovery before you're back.
And as you mentioned PT, is there value in doing PT prior to the replacement?
Absolutely. So, I think we talked a lot about how the joint does better the more stable it is, and the more strength that you have in that knee ahead of time, the better. It's going to shut down for a while after surgery. So once you have the operation, the muscles are going to go weak because you're not using them as much, and those muscles atrophy quickly. They've done studies where they've taken healthy 20-year-old college students and put them into a cast for a week, and they'll lose 30% of their muscle mass. So you can lose muscle mass quickly, and that's a healthy 20-year-old college kids versus more elderly or older patients. And the more you can build that muscle mass up ahead of time, the less likely you're going to have as much atrophy, and you're going to have more muscle to work with for sure. Just in terms of recovery, we did a study, this is probably about 2 years ago, where we gave patients Apple Watches and tracked them for about the 6 to 8 weeks before surgery, and then tracked them for a whole year after surgery. And so when you have the operation, say you start at a baseline level, you're going to take a hit and go down probably for that first week and a half, 2 weeks, in terms of how many steps a day you're taking, how many stairs you're climbing, how long you're standing. And then after that, you start to come back up. It's usually between that, around that 6-week mark, where you've gotten past where you were preoperatively in terms of like how long you're standing for, how many steps a day you're taking, how long you're walking for. And then you continue to improve. It probably starts to plateau around 3 months. And then instead of that sharp improvement, it creates this kind of slow, steady incline. But we found patients improving all the way out to a year from surgery in terms of what their strengthening and everything is. So you can still get a lot of improvements even all the way out to a year after the operation.
I felt like I saw a lot of variation in how people recovered. Yeah. And I definitely think having the appropriate expectations always helps, just knowing this is going to hurt and this is definitely going to not be your normal days following surgery.
I think that preparation helps. I think the other thing is that everybody experiences pain differently. It doesn't make you a good or bad or person, but it's just pain is a very subjective thing that patients experience very differently. And I tell patients, look, if you're a diabetic, it's because your pancreas doesn't make insulin. If you have more pain than somebody after surgery, it might just be because your nerve endings are more sensitive than others. And we get you through it. It's just everybody's comes to the table with a little bit different genetic makeup, and we just got to manage that. I think it's natural instinct that you're in therapy and you're next to somebody who had their knee replaced around the same time. You're like, what's your emotion? What's your emotion? Everybody wants to compete a little bit.
So don't give up if you're not feeling like you can do everything you want to do a month after your knee. It's still going to be healing, and it's still going to be getting better.
One question, we're talking about total knees. Is there ever a place for a partial knee replacement?
Yes, and I do a fair amount of partial knees. Partial knees are probably about 15% of my practice. So the idea is that the knee joint, so just from an anatomy standpoint, it's where the femur and the tibia, so the thigh bone and the shin bone meet. And the femur has 2 condyles or rounded ends to them. One's on the inside and one's on the outside, so medial and lateral. And then there's a joint also between your kneecap or your patella and your femur. So there's really 3 joints inside the knee joint. And that's part of the reason that it's so painful. It's more painful than hip replacement surgery. It's a complex joint. As you bend and straighten your knee, it rotates. There's 3 times the amount of nerve endings in the knee as there are in the hip. It's a bit more complex joint. But if you have just worn out a portion of your knee, the most common one is the inside part of the knee, the medial part of the knee. So somebody with that bowed or varus alignment of their knee, if you've just worn out the inside part of that knee, then we can just replace the inside part of the knee. If the outside part of the knee and the lateral joint and the patellofemoral joint, that kneecap joint, cartilage looks pristine, you have good intact ACL ligament, and you've just worn out the inside part of the knee, I tell patients we can't do better than what God gave you. And if what God gave you is good, we're going to leave that alone and just replace the inside part of the knee. And then patients usually next question on that is, do they last as long as a total knee, right? If I'm going to have a partial knee and then 5 years later, I'm going to need a total knee replacement, let me just have the total knee replacement and move on with it. And the data behind that is a little deceiving because if you look at surgeons that do a high volume, say more than 5 or 10% of partial knee replacements, so they're doing 100 or so partial knee replacements a year, it's technically a little bit harder of surgery. Instead of when a total knee replacement, you're replacing the entire tibia. So I tell people if you're trying to land a helicopter and you have this giant tibia to land it on, you're probably more likely going to land it in the right spot. Now, we're going to cut that into a third and try to land it perfectly on that third. It's a little bit more challenging. If you don't do a fair amount of them and you're just doing 1 or 2 or 3 or 4 a year of partial knee replacements as a surgeon, probably not doing enough to be good at them, to be able to do them well and make sure that you have good outcomes. And so when we look at data and literature that is what we call registry data, so it takes everybody in a certain country or area and looks at all their outcomes, partial knee replacements probably get revised a little bit more than total knee replacements in that data. But if you look at, say, a high volume surgeon that does a lot of partial knee replacements, the risk of needing a revision is no different than the risk of needing a revision after total knee replacements. The other thing that's helped us a lot with partial knee replacements, and this is probably a change in the last 5 to 10 years, is technology. There's been this robotic technology that's come out where we can get a CT scan of a patient's knee before surgery, map out the end of the knee during the surgery, and then use a robotic arm to very precisely make the cuts that we need to put the parts in. And it allows us, again, to just be more exact and precise of exactly where we're putting the implants, the angles and the degrees that we're cutting the bone at to match the patient's bone anatomy and the ligamentous tension of their knee so that it has the best mechanics. And if you look at just the robotic partial knees and you take out the non-robotic ones, those ones last just as long as total knees too. So I think it's a little bit of technology that's helped us get a little bit better at really hitting that smaller target and doing it well. There's a lot of benefits to a partial knee if you're a good candidate for it. So the knee feels more like a natural knee. You keep your ACL ligament, where in a total knee that comes out. And so the ACL ligament has a lot of what we call proprioception fibers, where it allows you to know where the knee is in space. And so that feeling of knowing where my knee is and the stability to my knee, so it feels more like a natural knee. So when you study patients that have had a partial versus the total, the partial patients, better knee society scores or better functional scores related to their knee function. They take less pain medication. They've got a quicker recovery. They've got a lower infection rate. Again, if you're a higher volume person or you're using this robotic technology, I really think that the chance of needing a redo of a partial knee is the same as needing a redo of a total.
You mentioned CT scan before. When you've had a knee replacement, is there any type of scanning, CT, MRI, anything that you need to avoid going down the road?
The answer is no. All of the implants from an orthopedic standpoint, and this really is true for a hip replacement, a knee replacement, a shoulder replacement, any plates or screws, rods that you get put in your body, the modern ones that we're putting today are all compliant with getting an MRI or getting a CT scan. Absolutely fine. The one thing is that if you needed a MRI or a CT scan of that joint, so say you got your knee replaced and then you got an MRI of that knee, it wouldn't be very good quality. So the metal in there creates a lot of artifact on the scan that makes it really hard to see any of the images that you want to see. It looks like scattered. And so it doesn't give us a great picture, but it's safe to get, if that makes sense. But most of the issues come up of, I had a knee replacement, but I need MRI on my back. Is that okay to get? And that's absolutely fine to get.
What about when you're going through the airport?
That's right. I was TSA going to
Yes.
do a strip search on me or something.
Yes.
Right? No. And so there's over 1 million knee replacements done in this country every year. And this is one of those, again, historical things of 20 years ago or 25 years ago, before 9/11 and things like that. Patients used to get these cards and somebody with a Sharpie would write on there, Miss Smith had her left knee replaced on this date. And they'd show it to TSA and security to let you go. You'd obviously think how easy that is to forge or make up. We don't give out any cards, but it's very safe to travel. The security agents at the airports are very used to it. Again, over 1 million knee replacements done in this country every year. You let them know you had a knee replacement, they'll wand you and scan you, but let you go on your way without any really extensive searching.
And another one that comes up a lot, am I going to have to take an antibiotic every time I go to the dentist?
I would say the antibiotic before the dentist is probably one of the more controversial things in our field. So when we have our big meetings every year where all the hip and knee replacement docs get together, we usually do it in Dallas every year. There's a big meeting where we present all the latest literature and we debate kind of things like this. And it's definitely a mixed bag, right? So some surgeons never give it. Some surgeons give it for everybody. And so when something's like that, where it's really split, even amongst the experts, there's probably no really good answer. It goes back to what we talked before about things that are easy to study, like nutrition is a really hard thing to study. This is a really hard thing to study as well, because you really got to track like how compliant people are with taking the antibiotics before the dentist. So just to back up a little bit so listeners can understand what we're talking about is that there's a thought that the bacteria that naturally live in your mouth that are supposed to be there, when you're having dental procedures done, they can cause some bleeding in the gums, and the gums are really vascular. So some of that bacteria could get into your bloodstream and then end up going to the knee and cause an infection. And we talked about what a big catastrophe an infection in a joint replacement is. So what some people have thought is if we give you an antibiotic prior to your dental procedure, so there's an antibiotic on board in your system at the time they're doing this work in and around your gums, it can help prevent an infection from going to your knee. So again, trying to study this from a compliance standpoint would be like, did the patient actually take it? And then did the amount of patients that have to take it to prevent one infection, right? So it's still a pretty rare thing. It doesn't happen often. And so trying to study a really rare thing in a lot of patients where compliance is an issue becomes really challenging for us to do. There's mixed literature on it where some people have shown that it makes a difference. Some people show that it doesn't make a difference. And so there is very split and there's debate on it. My thought process on it, and I take care of a lot of the infections like we talked about before, is a couple times a year I'll have somebody come in and they had their knee replaced in California 20 years ago, and they show up with an infection in their knee from a bacteria that is known to only grow in the mouth. So it happens, and it definitely happens. And so we see it, and when that happens, it creates this huge life event of needing 2 extra surgeries, being on IV antibiotics for 2 months. And so I think most things in medicine are a risk-benefit analysis of how much risk is involved in taking 1 dose of an antibiotic that you're not allergic to. And it's really, you just take that 1 dose an hour before a dental procedure. You're not on it for 5 days or anything like that. And then the consequence of that 25% mortality rate from having a knee infection at 5 years. To me, if it was my knee, I think to be on the safe side of taking that antibiotic just a couple times a year makes a lot of sense to me, just prophylactically to be safe. And that's what I tell my patients. But I definitely say that with I don't have great literature to support it. And I think there's still a continued debate even in our kind of medical world about what the right answer is there.
That's why you get different answers.
Yes,
right.
exactly. If someone is starting to have some knee pain, when is the best time for someone to see an orthopedist, and how can someone see you?
I think it goes back to that quality of life thing. I think there's going to be the times in life where you're getting older and you woke up on the wrong side of the bed and, oh, my knee's aching me today. But if it's something that's consistent, if it's going on for weeks at a time, it's affecting your quality of life and you can't do the things you want to do, I think that's time when you should go in and get it checked out. It's worthwhile having somebody evaluate you. And even if it's early onset things, they can get you involved in some of the things that we talked about, whether it's an oral anti-inflammatory to help with your symptoms so that you can get back and doing some exercises to work on muscle and strengthening around the knee and be a bit preventative on that. And then we're pretty easy to get into. So we work at Bluegrass Orthopedics. If you Google that, there you can probably put a link onto the website on the show notes. And then we've got tons of different ways to get in to see us and be evaluated for hip or knee arthritis.
Great. You've taught us so much. Is there anything you feel like we've missed?
No, I think that was pretty comprehensive. It's amazing trying to get all of these answers into a patient's preoperative when they're coming in to see
Yes.
Yeah, like, how long have we been recording? Your visits aren't that long.
My medical assistant gets really mad at me when they are.
But yes. I'm going to summarize just a few things that you said, and then we'll let you get out of here. But things to just remember that might increase your risk of osteoarthritis of the knee would be being overweight, having had trauma to the knee in the past, or you may have some sort of abnormal alignment where your hip and knee and ankle are not in that normal straight line. Also, there may be some genetic component, and I bet we will learn more about that in years to come. But things you can try to do to be proactive would be being as active as you can, doing resistance training, and actually putting some load. So not just walking with your body weight, but adding some additional weight. And then if you can actually lift weights, go ahead and start doing that. Start low and gradually go up. But you might be getting arthritis if you are getting really stiff when you get up to move, and then that pain might get better temporarily and then worse again as the day goes on and you're more active. So if those things start getting worse, you start having inability to maintain the things that you enjoy in life, then that's when you need to go see the orthopedist. But you may have other options. You may be able to take meloxicam or rub Voltaren gel on to help. Also, don't forget that it is important to think about your nutrition, particularly protein, and making sure that you are giving your body the building blocks that it needs. You also could consider turmeric in that stage where you're towards the beginning of things. And then you may have to progress to knee brace or injections. You gave us a lot of good information about the different types of injections. And basically, all of those are just Band-Aids trying to get you symptomatically feeling better until ultimately you might get to the point where you actually need a knee replacement. And that's usually when it really, truly is affecting your quality of life. And now the knees look like they're lasting a good 30 years, which is great. So remember, your doctor is not just trying to be difficult if they're giving you specific goals to reach before you can have surgery, like making sure your A1C is down less than 7 or that your BMI is down less than 40. They're really just trying to prevent infection because having a joint infection can be so devastating. And then not all knees require general anesthesia, so that can be a big relief to a lot of people knowing that they can just get spinal anesthesia. And also realize you can do these outpatient. You might have a reason that you need to be inpatient, but making sure that you are prepared and you have the appropriate support at home is going to be your best way to recover from this. So hopefully you never need a knee out there, but mine are feeling a little stiff after sitting here. Hopefully this will be helpful to you. And let us know if there's any other questions you have from us as far as knees, and we can always reach out to Dr. Denehy again.
Please join us next week. We will start talking about back pain, and we have an interventional pain specialist, Dr. Sean Milburn, who will come talk to us about managing chronic back pain. So we hope you are enjoying this new series.
See you next time.